Good morning, everyone. My name is Robert Hersey. Happy Tuesday to each of you. And on behalf of FATA, welcome to today's webinar titled Residential Intensive Treatment Services, Guiding Adolescents Towards Hope and Healing. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel. The chat panel is usually located on the upper right side of your monitor. We will answer questions throughout today's presentation. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to unmute, then click the switch audio connection button. Click disconnect, click the up arrow and switch audio connection buttons again, then click call in using the computer and follow the instructions on the screen. If you continue to experience poor audio through your computer, try using the I will call in option. The access code and event password will be posted in the chat panel momentarily. Please note you must be connected to the audio of this presentation and view it on screen to receive a statement of credit. We are unable to verify your attendance if you are not connected to WebEx via a computer or mobile app. Therefore, call-in only attendees are not eligible for a statement of credit or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credit earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through FATA. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the evaluation after the webinar is necessary to receive CEUs or to access your statement of credit. Please note that the evaluation will close at the end of the day on Friday, May 23rd, 2025. At the end of today's webinar, you will have 3 opportunities to complete the evaluation: a link we post in the chat, a follow-up email from WebEx, and an automatic web browser pop-up when we end the webinar. To complete the evaluation, you will first need to register or sign into your account. Please ensure that your name and email address match the name and email you used to attend this webinar. Information you provide FATA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your license or certification number when you register with our site. If you need assistance with account registration, login information, or accessing the evaluation, fill out a contact form on our website or email training@floridabha.org before May 23rd, 2025. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of credit if you do not attend the entire webinar, and we are not permitted to provide partial CEUs. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be reported to CE Broker within the same time frame. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today is Dr. Alexandra Felpeto. Dr. Felpeto is a Miami native who earned her bachelor's from the University of Miami in 2016, her master's degree in clinical psychology from Nova Southeastern University in 2020, and her doctoral degree in 2023. She completed both her pre-doctoral internship and postdoctoral residency at Citrus Health Network. Since April 2024, she has served as a clinical coordinator of the RITS SRT at CHN, focusing on short-term residential treatment for at-risk youth. Dr. Felpeto has worked with children and adolescents since 2020 and strongly advocates for expanding short-term residential programs throughout Florida. Her dedication lies in promoting evidence-based care, reducing barriers to treatment, and guiding young people toward healthier, more resilient futures. And now I would like to welcome our presenter, Dr. Felpeto. Dr. Felpeto, I will turn it over to you.
Good morning, everyone, and thank you for joining us today. I've seen that some of you have gone ahead and started posting your names, where you're from, and your agency on the chat. So I do want to take a minute to encourage that. Continue posting your names, your agency, as well as where you're from. That way we can gauge where the interest is coming from. I also wanted to go ahead and welcome our administrator, Ms. Kay Lewis. She is on the call with us, and she will be answering some of your questions either on the chat as well as throughout the presentation. Thank you, Ms. Lewis. All right, so without further ado, I'm going to go ahead and get started on presenting on the RITS Adolescent Short-term Residential Treatment Program, Guiding Adolescents Toward Hope, Healing. This is an introduction and overview. So for today, the learning objectives include identifying key program components. So by the end of this webinar, participants will be able to describe the purpose, scope, and the clinical services that are offered through residential intensive treatment services. The short-term residential treatment facility and integrated juvenile addiction receiving facility program. So we will also understand the admission and referral criteria. So attendees will learn how referrals are made, what documentation is needed, which includes voluntary versus involuntary criteria, and the role of managing entities and court orders. Additionally, we will differentiate among treatment settings. So participants will be able to distinguish the SRT, short-term residential treatment, from both CSU, which is the Crisis Stabilization Unit services, and the long-term statewide inpatient psychiatric programs, or SIP. Finally, we will identify key clinical practices and outcome measures. So participants will gain insight into evidence-based therapies, trauma-informed, and culturally responsive approaches, the importance of family engagement and discharge planning, and how program effectiveness is tracked through outcome data. All right, so just briefly about us, I'm going to talk first about Citrus Health Network as a whole, and then I will talk about the RITS Short-term Residential Treatment Facility. So Citrus Health Network is a leading nonprofit healthcare provider in South Florida, delivering accessible and affordable services to both adults and children since 1979. With a total wellness approach that integrates physical, mental, and behavioral health care, Citrus addresses the whole person to meet their unique needs. Guided by a commitment to community, collaboration, and innovation, we strive to create a healthier future for all. Now, with respect to our short-term residential treatment services, the RITS unit opened in September 2023 on the 3rd floor of our main center in Hialeah. It provides 16 secure beds for adolescents in need of comprehensive mental health services. In the spring of 2024, the program obtained Juvenile Addiction Receiving Facility, or JARF, licensed, integrating short-term residential treatment, so the mental health component, as well as addiction support under one roof. It's currently the only locked short-term facility of its kind in Florida, further underscoring our commitment to filling critical gaps in adolescent mental health care. All right, so now I'm going to talk a little bit about the RITS mission and vision. So our mission is to provide a structured, compassionate, and intensive residential experience. The average is up to 90 days, and it fosters emotional stability, personal growth, and recovery for adolescents in crisis. Through individualized therapy, medication management, 24/7 nursing care, and robust behavioral interventions, we ensure that each young person receives a holistic approach. We're guided by our vision of guiding adolescents toward hope and healing, and we strive to equip every adolescent with the skills, the resilience, and the optimism that they need to transition successfully back into their community. All right, so a little bit about the RITS program. So as I said previously, we are located in Citrus's main center in Hialeah, Florida. The unit is located on the third floor of that building. At maximum capacity, we have the potential for 16 beds to be occupied. The population we serve are youth between the ages of 13 to 17 years old. Typically, what we see is mental health diagnoses and co-occurring substance abuse diagnosis that are typically experiencing an acute or subacute crisis. As I said again, RITS is the first locked short-term residential treatment facility for children in Florida. All right, so now I'm going to talk a little bit about crisis stabilization and the Baker Act. So SRT affiliation. An SRT must be affiliated with a designated Baker Act receiving facility. So we are affiliated with the Citrus Health Network Children's Crisis Stabilization Unit, which is in this same building, however, it's on the first floor. The purpose of SRT. So we provide a state-supported acute care residential alternative for patients of CSUs, inpatient units, or designated public and/or private receiving facilities who need additional treatment for psychiatric conditions. I'm going to talk a little bit about the eligibility requirement. A youth must be actively admitted to a crisis stabilization unit, an inpatient unit, or a designated public private receiving facility in order to be eligible for the SRT. Referral nullification. If the youth is discharged from a CSU or an inpatient unit prior to SRT admission, then the referral is considered nullified. So a little bit about our inclusion criteria. So just a disclosure, a brief disclosure, a child does not need insurance in order to be eligible for the RITS SRT or for the RITS JARF program. It's intended for patients who meet the Baker Act criteria, and there are specific inclusion criteria to include a diagnosis of a severe and persistent mental illness per the latest DSM-5-TR. The ages are between 13 to 17. The youth must be continent, ambulatory, or able to self-transfer. They must be classified at a middle school level or higher educationally, as we do have school on site, and our teachers specifically teach at a middle school level or higher. They must have an IQ of at least 70, capable of participating in the treatment program, free of any major medical conditions that require 24-hour nursing care. They also must be able to maintain their hygiene and engage socially with supervision. So now I'm going to talk a little bit as to the RITS exclusionary criteria, and I'm going to give some of those reasons as to why they're excluded. So a youth that's outside of the 13 to the 17 range. The rationale is that the program's therapeutic curriculum, the peer groups, and the developmental interventions are designed specifically for adolescents. So individuals younger than 13 or older, they would not benefit from the targeted approach, or they may require different resources altogether. A diagnosis that does not meet severe and persistent mental illness standard. So the rationale for excluding this population is that the program is structured to serve those with significant mental health conditions that require intensive intervention. Mild or situational mental health concerns may be more appropriately managed in a less restrictive outpatient settings. Essentially, we do not want to traumatize a child by having them in a locked facility when they are able to seek outpatient services and services out in the community. So a child that's not consonant, non-ambulatory, or unable to self-transfer. So the rationale as to why they are part of our exclusionary criteria is that the facility is not equipped for continuous medical or mobility support, although it does meet ADA requirements. The patients must be able to navigate the environment and care for basic personal needs with minimal assistance, as the program focus is psychiatric and therapeutic rather than a medical rehabilitation. An educational level below middle school functioning. The rationale is that the program activities, including group discussions, homework, psychoeducation, assume a middle school level academic foundation. Participants below this level may struggle to engage meaningfully or benefit from the curriculum. Additionally, the psychiatrist places the patients in the hospital-bound education program, where the Miami-Dade County Public Schools, as I said previously, these teachers are eligible to teach middle and high school students only. An IQ below 70. So the rationale for this is that the therapeutic interventions rely on a certain level of cognitive functioning to process information, learning coping skills, and participate in group sessions. An individual with an IQ below 70 requires a more specialized program or additional supports. Now, as to the major medical conditions that require intensive medical intervention beyond the facility's scope, the rationale for this is that although the facility has 24-hour nursing and psychiatric care, the adolescents with complex health issues that demand specialized medical equipment or procedures beyond basic nursing tasks would be better served in a setting that's equipped for comprehensive medical oversight. All right. So now I'm going to continue talking about the RITS exclusionary criteria. Another exclusionary criteria are cognitive impairments that significantly limit benefit from the SRT. The rationale for this is that these impairments can prevent a youth from fully participating in group activities, therapy sessions, or socialization opportunities. They would benefit more from a specialized program that's tailored to their developmental or cognitive challenges. Another exclusionary criteria is those youth that aren't able to participate in the treatment program. The rationale behind this is that the therapeutic model is participatory. A patient who cannot engage with therapy groups, counseling, or structured daily activities cannot meet the treatment goals. Furthermore, inability to maintain basic hygiene and care is exclusionary as well. The rationale for this is that the program expects clients to practice and reinforce independent living skills under supervision. The purpose of this is that we are essentially training them to be out in the community. So they need to be able to have these skills for themselves once they are discharged. Youth cannot or refuses to maintain personal hygiene, even with staff prompts. They may need a higher level of care or a more specialized setting. History of physical aggression or significant suicidal and/or homicidal behavior. So safety is paramount. The program is structured for adolescents who are not actively dangerous to themselves or others. Individuals with a history of repeated severe aggression or acute suicidal, homicidal ideation need a higher acuity setting. Last but not least, cognitive or neurodevelopmental impairments that limit benefit from the services. So youth whose developmental, intellectual, or cognitive impairments prevent them fully from participating in group-based therapy, psychoeducation, and skill building would not optimally benefit from this environment. They require either specialized interventions or programs designed for significant developmental delays. So now I'm going to talk a little bit about the SRT admissions process. So I know that this slide is heavy with information, but I'm actually going to break it down step by step. There's about 8 steps or less, depending on whether the patient is a community or a dependent youth and whether the unit requires additional documentation. All right, so for the first step in the admission process, the youth meets Baker Act criteria and is admitted to a crisis stabilization unit, an inpatient unit, or other designated Baker Act public or private receiving facility in Miami-Dade, Monroe, or Broward counties. So for the second step, the psychiatrist in the admitting Baker Act facility determines that the youth would benefit from SRT services. The referring clinical team consults with the RITS clinical team to determine if clinically appropriate and no primary care medical barriers are anticipated. RITS may request screening of the patient or additional documentation. The documentation required will be elaborated upon in further slides. Now we move on to the next step. So prior to admission, referral forms and psychiatric evaluation and the order, so court orders provided to the corresponding managing entity. At this time, we have two managing entities. We have for our Miami-Dade and Monroe beds, we have Thriving Mind, and for our Broward beds, we have BBHC. For dependent youth, the corresponding community-based care lead agency must also be notified by the managing entity that the youth is being considered for SRT admission. All right, so the psychiatrist or the physician of the referral facility orders the youth to be admitted to the SRT either upon voluntary consent of the youth parent or guardian and the youth assent. The legal guardian will be asked to complete an admissions packet, which must be completed and provided with the order prior to admission. If cleared, the referral source will receive notification in writing, including an admission date and time. So essentially for community youth, both the child and the parent have to consent and assent to being admitted into the RITS unit. For those in custody of the state, a court order must be obtained prior to the child being admitted to the unit. All right, so if no consent is given, the psychiatrist may petition the probate court for involuntary inpatient placement to include SRT. So that's if a community child does not consent. The probate judge orders youth for involuntary inpatient placement to include SRT. Please note that a criminal court order is not sufficient for involuntary placement. Now, the same would occur for a dependent youth. So the psychiatrist petitions the probate court for involuntary inpatient placement. All right, step number 6. So if additional required documentation is requested, then the referring facility can go ahead and send that over to the RITS unit. When all materials are successfully completed, then the youth is admitted to the RITS unit. So for youth in DCF custody, I just want to make sure I repeat this so it's clear. A court order is always required. Youth in DCF custody must have a court order because the state, not a parent or a private or a guardian, is responsible for consenting to their care. And the state law mandates that judicial approval is given to protect the youth's rights and well-being. All right, so now I'm going to talk a little bit about the court order. So prior to obtaining a court order, a physician or a psychiatrist must order that SRT is the appropriate next step. So a minor may be admitted voluntarily with proper assent of the minor and consent of the parent and legal guardian. The physician from a CSU or designated public private receiving facility may petition the Baker Act or probate court for involuntary placement if the minor meets criteria and does not assent to being admitted. So this slide talks a little bit about the Florida Administrative Code 65E, which allows voluntary admission of a minor with guardian consent and minor's assent. And it also talks a little bit about Florida Statute 394.467, which governs the criteria and the procedures for involuntary placement under the Baker Act. So now I'm going to talk a little bit about the referral documentation. Again, this slide is a little bit heavy with text material, but I will go ahead and break it down in further slides. All right, so the required documentation in order for a referral packet to be considered completed. First, a referral from a psychiatrist is required. Then a completed SRT application. We do have our own SRT application, which I could actually go ahead and forward to Robert so he could go ahead and send that out if he wants to. That way you guys have a copy of what our SRT application looks like. A psychiatric evaluation, so the most recent psychiatric evaluation from the attending psychiatrist at the CSU or inpatient unit. The most recent medical evaluation, recent lab results, immunization records, birth certificate, their social security card, their school records, their most recent school records, and if the child has an IEP or a 504 plan, and their insurance card as well. Please note that whether the child has insurance or not is not necessarily an eligibility requirement for SRT. For community children, the patient's legal guardians must provide consent for the patient to be admitted, and the patient must provide assent. I know I've repeated this multiple times, and I'll continue to repeat it multiple times throughout because it is important to have both patient and guardian consent and assent, as it has happened where they have changed their mind once they are in the unit, and then that looks like an entirely different process, which I could also get into in future slides. So for children in the custody of the Department of Children and Families, a court order from probate court must be obtained in order for the patient to be admitted. All right, so the average length of stay in our unit is anywhere between 60 to 90 days, depending on the court order and the physician's clinical opinion. I don't have this on this slide, but recent Florida legislature is actually permitting for SRT to ask for up to 180 days. So that would be about 6 months. And so the courts are now allowing us to ask for that time frame, or for the referring psychiatrist to ask for that time frame, dependent on the child's needs. But the average length of stay is typically 60 to 90 days. All right, so now I do want to talk a little bit about the differences between a short-term residential and a statewide inpatient psychiatric program. So the differences between SRT and what's required for admission. So an SRT must have a physician or a psychiatrist order. If the child is admitted involuntarily, a Baker Act probate court order is required. For SIP, youth in the Department of Children and Families, or DCF custody, undergo a suitability assessment, while youth in parent and guardian custody, a psychiatrist recommendation. So the approximate length of stay in SRT is anywhere from 60 to 180 days based on court order and the attending physician's clinical judgment. And in a SIP, it's generally 6 months or longer, which provides more extensive long-term care. Now, the treatment setting also varies. So in an SRT, we offer a higher level of care for adolescents who no longer require acute crisis stabilization, but they still need the additional support before returning to the community or moving on to a SIP facility. So we are considered a higher level of care from a crisis stabilization unit. However, we are considered a step down from SIP. If the child requires higher level beyond SRT, then that's when we possibly recommend SIP placement. Now, the SIP treatment setting and the focus, it's more intensive of a residential setting, and it's designed for longer term treatment and a deeper stabilization for more severe or persistent psychiatric needs. So continuing on the differences between SRT versus SIP, the SRT serves as a potential diversion program from SIP by providing a structured environment where clinical teams can evaluate whether a child truly requires longer-term inpatient care or can be stepped down to community-based care. In many cases, with appropriate intervention, the youth may stabilize during their SRT stay and no longer meet criteria for SIP. However, if SRT reveals ongoing intensive psychiatric needs, the program also facilitates referrals and transitions to SIP when necessary. The SRT is also considered an extension of the crisis stabilization unit. So our SRT operates as a direct extension of Baker Act designated facilities. And admission to the SRT is considered a transfer from one Baker Act receiving facility to another. So eligibility requires acute or subacute crisis. So coming into SRT, a youth may still be in crisis, needing more stabilization than a SU, but not yet requiring SIP's longer term services. SIP suitability assessment is not an automatic into the SRT. So just because you receive a SIP recommendation doesn't automatically qualify a youth for SRT. Each placement decision is based on the current level of crisis and the most appropriate service level. And of course, the milieu as well. I want to take a brief pause. If anyone has any questions, please do consider putting them in the chat, and Ms. Kay Lewis will continue to answering. I actually just took a brief pause because I do have Miss Kay Lewis in the room with me, and she said that one of the most recent questions is, I'm sorry, what was it? So is whether the court order that's required a Marchman order or a probate court order. So that's an excellent question, and I will be able to answer that moving forward, but I can go ahead and take a minute to answer that. So a Marchman order is for those youth with substance use concerns that are considering treatment in our JARF program. So in that substance use program, a probate court order is what's required for our SRT program, so our mental health program. So our program is integrated. It's part mental health, part substance use. So an order is for the substance use component, probate court order is for the SRT or mental health component. All right, so I'm going to go ahead and just talk a little bit about a recent patient that we had here at the SRT, so the mental health part of our program. So I'm going to talk about their presenting problem, what the course of treatment looked like, the outcome of treatment, and the discharge component. That way you guys can really get an idea of how comprehensive our treatment is. So the presenting problem. We admitted a 15-year-old female. She was admitted to the RITS program early September 2024. She had a history of self-injurious behaviors, suicidal ideation with attempts, homicidal ideation, loss of appetite, and illicit drug use. The patient demonstrated maladaptive behaviors, mood dysregulation, aggression, impulsivity, and ongoing family conflict, necessitating intensive intervention. So I know, so while she was self-injurious and she had suicidal ideation, there was also illicit drug use. So at that time, when she was admitted into a CSU, the attending psychiatrist would decide, okay, what is more acute at this time? What does this patient need more at this time? Does this patient need more of a JARF component, or is the mental health component the primary or the predominant factors that we need to take a look at? So because she was SRT, the attending physician went ahead and petitioned the probate court for a probate order. The patient demonstrated maladaptive behaviors, mood dysregulation, aggression, impulsivity, and ongoing family conflict, necessitating intensive intervention. So for the course of treatment, during individual therapy, she worked on improving her self-esteem, anger management, body image issues, and substance use awareness. The patient learned new coping strategies, she practiced relaxation techniques, and explored the influence of family dynamics on her emotional well-being. So a lot of her issues stemmed from what was going on at home. She also addressed grief, bipolar-related symptoms, and anxiety triggers while gradually adopting more adaptive coping methods. In family therapy, she and her relatives focused on better communication, trust building, and establishing structured living arrangements. Therapeutic activities aimed at emotional expression and conflict resolution helped reduce misunderstandings and increase the family's overall insight. Now, a little bit about the outcome of treatment. Over the course of her stay, the patient demonstrated growth in awareness and emotional regulation and a willingness to engage in therapeutic activities. Though initially resistant to fully accepting her bipolar diagnosis, she benefited from the psychoeducation component and continued to practice coping strategies such as meditation, creative expression, and grief work. Her family showed improved communication skills, creating a safer and more supportive environment. So what did the discharge component look like? So after successfully completing the program's highest level of privileges, or our level D, which I will get into what our program actually looks like in all the different levels, she was discharged in December 2024. She received a 7-day follow-up, which is a medication management appointment. It was scheduled and she was able to attend with the psychiatrist. A suicide risk assessment and a safety plan were completed prior to her discharge, reflecting her progress and readiness to continue healing with outpatient support. So at that point in time, she received all of her referrals for community-based programs, whether that be a community teams, where she received individual and family therapy services at home, psychiatric med management appointments, possible referrals to whether it's Narcotic Anonymous or Alcoholics Anonymous or any other program that we might refer to address the substance use. So we go ahead and we also refer them to programs in the community as well. All right, so I'm gonna ask this question, and then I'm gonna take a brief pause so that you guys can go ahead and think about it and start commenting and answering in the chat. So before we move forward, I wanted to take a moment to hear from all of you. The reality is that every region, agency, and the role experiences different barriers when it comes to accessing care for adolescents, and your perspective is valuable. So from your experience, what do you see as the biggest obstacle in getting adolescents timely access to short-term residential treatment? Please type your thoughts in the chat.
One of the comments was financial means. So DCF does fund through the managing entity the beds that are provided here at RITS. So insurance would not be an issue. I see a lot of people have put funding, obtain the required documents from all the other providers. So once we get into more in depth with the slides, Dr. Felpeto will explain some of the forms that are being requested, which are some of them, depending on the family, they may have some in their possession. If they're DCF youth, it may be easier to get those forms together, but it is a collaboration. And obviously there are some forms that are required, and there are some that we can probably get along the way. Required court orders, I see. Yes, that's absolutely correct. Sometimes the court is very slow. They drag their feet. But because we're working in probate court, it's a sense of urgency because that youth needs those services immediately. So our hope would be that the psychiatrist or the doctor would make an effort to try as quickly as possible to get the case before the probate court to order those services for their patient. Availabilities of facilities or beds. We currently do have availability at this time at the RITS. I understand there's questions about whether or not other providers and other counties can facilitate or use these beds. Thriving Minds will make that final decision because they are the funding source through DCF. A couple of questions about the space and a lack of access to the areas outside of Miami. Understood. Because we are the first of its kind, it's why it was piloted here in Miami-Dade and Broward counties. We are the first locked facility for SRT services, which is mental health, and the first locked for JARF services. So we're like a combination of the two. So it's our hope maybe at some point there will be future ones across the state. There are teachers here who provide care and supervision to our youth here through Miami-Dade County Public Schools. They teach on site from 8 in the morning to 2:30 p.m. to provide them with the educational tools they need so they don't miss anything while they're here with us for the duration of their time they're here, which is why it's imperative that they're in middle school or higher to continue with their education. Males and females. So in reference to males and females, currently, the amount of referrals we receive have been an overwhelming amount of females. So because of that, we currently have a female unit at this time. However, we'll see how it goes. But for the clinical milieu, we're currently servicing a high level of female youth that present with HT and some other issues that require us to give them specialized services. There are parents who are absolutely willing to work with us when it comes to family therapy, and we are very inventive about giving those services, whether it's through via Zoom or in person. We try to work with parents and families who are working on the weekends or working during the day. We're kind of flexible about doing sessions at 7 p.m., 8 p.m. on the weekends, on Saturdays or on Sundays to try to facilitate those services to the parents so they're able to better understand the issues that their youth have in the program. So the youth do not have to be Baker Acted as Citrus Health. They just need to be at a Baker Acted receiving facility, right? So if there's one at Larkin, there's one at Jackson, there's one at Citrus. So they don't have to necessarily come from Citrus Health Network, CCSU. They can come from Larkin. They can come from, Florida Behavioral, as long as it's a transfer and the SRT has approved them and there's a court order in place, or the youth has assented and the parent or caregiver has consented to their placement here at the RITS. Yes, there are available beds at this time. I do think there is a lack of general court and public awareness about the program, which is part of the reason why we're excited to do this presentation at this time. And it is our hope that as we provide this information to you, that you'll also share this information with your counterparts so it will spread across the state. So the school teachers we have here currently are aware of our program. So even though it's 2 or 3 of them, we have continued to, speak to the school system about the program that we have here, and in hopes of people being aware of the services that we offer.
All right, thank you, Ms. Lewis. So I'm going to go ahead and actually offer a brief break because the next slides will touch upon our integrated JARF program and what that process looks like when a child is being referred to our substance use services. So I'm going to go ahead and give us a 5-minute break, and we will return at 10:45. Thank you, everyone. All right, everyone, welcome back. I'm sorry that it was such a short break, but hopefully you were able to either use the bathroom or recaffeinate. So I'm actually have Miss Lewis answer some of the questions that were just recently put in the chat. That way, we can answer anywhere from 3 to 5 of your questions, and then we'll go ahead and continue talking about our JARF program.
So based on the questions that I received, so at this time there is no allotment from this program because they go straight from the Baker Acton Receiving Facility and are transferred directly into the SRT if they're accepted. They do not have access to electronic devices here. There's no phones for them to use. The computers are monitored in the school setting with other staff present. Phone calls are also monitored. We've found since our existence for the last almost 2 years that most of our referrals are community youth. And because they're community youth, they actually assent to being here and the parents consent. So we do actually get their buy-in. And for the JARF component, it is the highest community involvement because they're aware that their youth have some type of substance abuse problem. The youth wants to get help, and the parents are definitely willing and committed to making sure that their youth get the help that they need. The parents are not required to transport them from the CCSU because transport needs to be done from facility to facility because it's considered a transfer. It's not considered a withdrawal from the receiving facility to us being RITS. And the last question that was asked is, why do we think there's so much more female referrals than males? Well, historically, what we found is that females are more inclined to kind of share their feelings and emotions. And it may be an overwhelming amount of Baker acts that are taking place with more female clients. And so because of that, the psychiatrists and psychologists are able to kind of make an informed decision, an assessment that says, you know what, they need a higher level of care than what we can do here in the CCSUs that we have. Thank you for your questions. At this time, we currently have a female unit. So the clinical milieu at this time may not support a male at this time because we have overwhelming females based on the referrals that we receive both in the community and through DCF.
All right, thank you, Ms. Lewis. So without further ado, I'm going to go ahead and talk about the RITS Integrated Juvenile Addiction Receiving Facility Program. So as I said previously, in the spring of 2024, Citrus received a JARF license to integrate substance use services with the SRT, or our mental health component. All right, so for the RITS JARF, here at Citrus Health Network, we have 2 JARF facilities under one roof. The first floor JARF, which is in our CCSU, or the Children's Crisis Stabilization Unit, handles new admissions and involuntary assessments. If the first floor is at capacity, or if there's a court treatment order in place, then the third floor, our JARF, RITS JARF, can admit a new client. For transfers, however, the third floor only takes involuntary referrals from the first floor JARF or another JARF within the county. And a Marchman court order is always required for SRT JARF admission. Typically, a youth stay will run anywhere from 60 to 90 days, guided by the court order and the bed availability, with an initial treatment order of up to 90 days before any extensions might be considered. So right now, what we're seeing from the Marchman court is that the treatment orders are for up to 90 days. Extensions have been given by the court, but after we go back to the hearing, which it's typically called in the Marchman order, it's called a TOS date, or a termination of services date, where you petition the court for either an extension or you don't need the extension and the child is ready for discharge. So the RITS JARF referral process. So if a youth is admitted to the juvenile addiction receiving facility, it becomes clinically evident that their primary need is psychiatric stabilization rather than the substance use treatment, a transfer to SRT. Oh, sorry about this. So what this is explaining is that, so the JARF referral process is very similar to our SRT referral process. So if the youth meets JARF criteria and is admitted to an integrated CSU or JARF under the petition for involuntary assessment, we go to the Marchman court and we receive a Marchment order. A petition for involuntary treatment may be filed by a parent, a legal guardian, or a clinician. So I know it says here Citrus Health, but again, it could be an attending psychiatrist. If the CHN clinician believes there's a need to hold the youth until the hearing, there is a Florida statute that allows the youth to be held pending further order of the court. If Citrus plans to hold the youth, the notice is provided to the court so that regional counsel can be appointed. If needed, regional counsel can file for expedited hearing or hearing on need to hold. If the court orders involuntary inpatient treatment, the youth is transferred to open treatment beds. If no bed is available, treatment may begin at the RITS JARF. So again, downstairs is typically where they go first. So downstairs is where they the involuntary assessment, and they're typically in a CSU prior to coming to us. However, if there's no treatment bed available in the crisis stabilization unit, then treatment may begin and they may be transferred up to the RITS JARF. The referral that's submitted from the CSUs and the court order, the required referral forms and the psychiatric evaluation has to be also sent to our managing entity. So any kind of referral, whether it's the mental health SRT referral or the JARF substance use referral, always has to go to our managing entity, Thriving Minds, and also to the community-based agency for those youth that are in custody. So I got a little tripped up before, and what I wanted to say is that if a youth is admitted to the JARF program, but it becomes evident that they have more mental health issues or that their substance use concerns are stemming from depression, anxiety, any kind of mental health concern, and that their primary need is now more psychiatric stabilization as well as individual therapy services that are focused on that mental health concern, a transfer to the SRT from the JARF program may be necessary. So within the same unit, you are a JARF child, you're here for your substance use concerns, but it's evident that your mental health concerns are predominant, we can do a transfer. So how does that look like? So the attending psychiatrist can initiate an involuntary placement under the Baker Act by completing a physician's certificate or a PC. So the case is then presented to the probate court for approval of continued involuntary treatment. Upon the court's authorization, the youth can be formally transferred from JARF to SRT, where the focus shifts to addressing their predominant mental health concerns in a structured residential setting. So this is actually something that we've seen where we've had a child that was been acted to our JARF program. And after a certain amount of days, we noticed, okay, their substance use concerns were stemming more from their depression, their anxiety, or from the disruption in their household. So we have then gone to probate court and we from JARF to SRT or to the mental health. So they went from a Marchment order to a probate court order. All right, so now I actually have another discussion question. So now that we've reviewed the process for admission to our JARF program, I'd like to pause again and get your input. Many of the youth we serve have co-occurring mental health and substance use needs, and coordinating the right level of care can be complex. As professionals, the questions we ask early on can really shape how successful that transition is. So imagine you're coordinating care for a youth with both mental health and substance use challenges. What questions would you ask the referring facility or the guardians to ensure a smooth transition to the integrated JARF SRT program? Please share your answers in the chat. And I'll take a brief pause so you guys can go ahead and process the question and type your responses. All right, so thank you. Some of those that you offered in the chat are exactly the types of thoughtful and diagnostic type questions that help guide treatment planning from the start. So next, I want to walk you through the key differences between the SRT and the JARF program so you can see how each is structured and meet different levels of need. and how together they create a more complete continuum of care. All right, so the differences between SRT and JARF. So what is required for admission? For the SRT, a physician or psychiatrist order and the court order from Baker Act Probate Court if the child is involuntary, or the consent and assent of the child and the parent. For the JARF referral process required for admission, always a court order from Marchman Court. So whether the child is willing to enter treatment or not, a court order from Marchman Court order is required. The approximate length of stay at SRT is anywhere from 60 to 180 days based on the court order and the physician's clinical opinion. The approximate length of stay for the JARF program is anywhere from 60 to 90 days, depending on the court order, and if alternative treatment, and if an alternate treatment bed is available. The initial treatment order is up to 90 days, as I said before. The treatment setting. So the treatment setting, in our case, it's the exact same treatment setting. So it would be all within the same unit. SRT provides a higher level of care for individuals who are no longer experiencing an acute or immediately subacute crisis, but need additional stabilization services prior to community placement or admission to a SIP facility. So both our SRT and our JARF programs are located within the RITS unit. Now, some of the key differences between SRT and JARF, although they're in the unit, whether you're SRT or JARF, you will always be receiving psychoeducation on substance use. You will also be part of our substance use and relapse prevention groups. However, JARF youth receive 2 individual sessions per week and also all the other treatment services. Mental health youth receive 1 individual therapy session per week. So that's really the key difference between SRT and JARF. The JARF receives 2. One is, an individual therapy session that's taking a look at the mental health concerns of the individual, and the other one is a psychoeducation individual session on substance abuse. All right, so now, just like I did for our RITS SRT program, I'm going to talk about a case vignette for our RITS JARF patient. So the presenting problem, it was a 15-year-old female that was admitted to our program in July 2024 for severe mood and behavioral disturbances, including suicidal ideation, self-injury, defiance of house rules, and substance use. She had multiple prior Baker Act admissions and was placed with foster guardians. Upon admission, she was in the pre-contemplation stage of change regarding her substance use. So this child needed a Marchman court order in order to be admitted. Throughout the course of treatment, her treatment focused on cognitive restructuring, mindfulness, communication skills, targeting negative self-talk, emotional regulation, and peer conflicts. She also engaged in CBT for substance use and motivational interviewing, which helped her progress from the pre-contemplation stage, or the first stage in the 5 stages of change, to a more receptive mindset. Family therapy sessions facilitated trust building, accountability, and healthier communication with her guardians. The outcome of treatment: she achieved notable emotional stabilization. She was able to develop healthier coping methods, greater self-awareness, and stronger family relationships. Family therapy led to improved communication, the creation of a family trust agreement, and a support environment. By discharge, she had moved into the preparation stage of change. So from where she was in the pre-contemplation, which is the first stage of change, to the 3rd stage of change, which is where you're making all those necessary plans in order to make the change, right? So because she's in a locked facility, it's kind of difficult to make that change while you're here. I mean, it's a controlled environment, so they're already sober while they're here, but what is that going to look like when she reaches the community? So she moved into the preparation stage of change. We reflected on her readiness to continue addressing the substance use. With respect to her discharge in mid-December 2024, she was successfully discharged at level D, reflecting her progress and her readiness for outpatient care. She left with a completed safety plan, a scheduled follow-up, and arrangements to continue DBT therapy, successfully transitioning back to the community with a stronger commitment to recovery. I did see this patient a month after she had been discharged from our facility, and she still was clean. So that was, really beautiful to see. say. And so now I'm going to talk a little bit about the staff roles and the interdisciplinary team. So what does the RITS team look like? So we have the residential unit administrator, who is Ms. Kay Lewis on the call. Her role is she oversees the overall operations of the residential facility. She ensures compliance with regulations and quality of care. She acts as the leader, coordinating between all staff members to align the facility's goals and policies, ensuring a cohesive environment that fosters effective teamwork. Then we have our administrative assistant, or the unit clerk. They manage administrative tasks, they handle documentation, they schedule appointments, they serve as a communication hub for the team, facilitating the flow of information between departments and ensuring all team members have the necessary resources to perform their roles effectively. We also have our attending psychiatrist. He provides psychiatric evaluation and treatment, including medication management, and is at the unit multiple times a week and is also on call 24/7. He works closely with nurses, therapists, and other medical staff to develop and adjust treatment plans, patients' progress, ensuring comprehensive care. Next, we have our 24/7 nursing department. So they offer medical care, they administer the medications, and they monitor the health status of the residents. They collaborate with the psychiatrist and the therapist to provide a holistic approach to care, sharing observations that might impact treatment plans. Next, you have the therapists, the psychologists, and the counselors. So their role is to provide therapeutic interventions such as CBT, group therapy, and other psychotherapeutic techniques. They work in conjunction with the clinical coordinator and psychiatrists to tailor therapies based on the patient needs, contributing to a multidisciplinary approach to mental health treatment. We have our discharge coordinator. So their role is to plan and coordinate the discharge process, ensuring that patients have a smooth transition from the facility to community care. The clinical coordinator, myself, is a licensed psychologist that coordinates clinical operations, supervises staff, and provides psychological services. They integrate various therapeutic perspectives and ensure that the treatment provided by different specialists is coherent and tailored to each patient's needs. Next, we have a team of lead behavioral health technicians. So they supervise our behavioral health techs, they manage crises, and ensure the implementation of care plans. Next, you have the behavioral health techs, who are under the lead behavioral health tech. The lead behavioral techs. So their role is to directly provide care to the patients. They assist with daily living activities and therapeutic intervention. So reminding the patients, use your coping skills, redirecting them from maladaptive behaviors. They work closely with the nurses and the therapists to provide care, and they report on patient progress. They play a crucial role in the day-to-day implementation of the treatment plans. Next, you have our support staff, the case managers, the social workers, the peer specialists, the teachers. They provide specialized care, including management, social support, peer mentoring, and educational services. And last but certainly not least, we have our facilities pediatrician. So they specialize in providing medical care for children and adolescents in the facility. They conduct physical examinations, diagnose and treat illnesses, and monitor developmental progress. So that's just a little bit about what the treatment team looks like here at the RITS unit. All right. Now I am going to go ahead and give you just a preview of what a typical day looks like while you're here. So a structured daily schedule in a residential unit is crucial because it provides consistency and predictability, while also serving as a valuable teaching tool for our youth. It reinforces the importance of routine, structure, and discipline, skills that are essential for success beyond the program. The schedule also helps manage expectations for the families, the resources, and stakeholders by clearly outlining the program's daily activities and therapeutic interventions. This transparency builds trust and ensures that everyone involved understands the treatment process and objectives. In addition to clinical structure, the program incorporates age-appropriate, enjoyable activities that support engagement and emotional connection. So we'll have different kinds of creative expression therapists come. Well, they'll create their own music, they'll create their own artwork, play sculptures, etc. Patients participate in supervised leisure activities such as movie nights, they'll make smoothies, they like to play board games, and we celebrate holidays, including religious holidays as well. So we help patients practice their religious beliefs while in our unit. They decorate the walls near their beds and they personalize their bedroom doors, which promotes a sense of ownership and comfort. The program also honors and accommodates various religious holidays, as I said, working with youth and families to coordinate respectful celebrations. These efforts acknowledge that at the end of the day, we are treating adolescents, individuals who deserve joy, dignity, and a sense of normalcy while they are in care. So I'm not sure how clear this slide is, but this is just to show you what our schedule looks like. So I know that the font is very small, but essentially they're waking up at 6:30 a.m. every day, except for Saturdays and Sundays where they wake up a little bit later. And they're going to bed pretty much consistently every night around 7:30, 8 o'clock. And they know exactly what their days are going to look like. So reducing anxiety as to what my day might look like, what's going to happen next. So they have a structured schedule while they're here. Of course, this schedule is, it can change at any time. So for instance, now we're entering the summer month where they won't necessarily have school from 8, they won't be having school from 8 to 2:20. So we incorporate other different kinds of activities. We'll incorporate home learning, more different kinds of creative expression activities, etc. All right, so I'm sure you guys are wondering, she's mentioned in those 2 case vignettes that they are successfully discharged on level D. What does level D mean? So we have, our program is essentially a behavioral modification program, and it's a level-based model. So it's designed to both motivate and educate the youth as they move through treatment. Each level, so we have 5 levels. The first level is level I for introduction, then A through D. For each level corresponds with a point threshold and clinical milestones, such as successful community or home passes, therapy participation, and adherence to unit expectations. So for instance, our level I, they're adjusting to the unit. It's the introductory level. So they might have to just earn a certain number of points before getting to level A. By the time they're on level B, they're getting food passes where they might have, so they typically have up to 2 food passes on levels B, C, and D, where they might want to order on a Friday Kentucky Fried Chicken. And so we'll go and we'll get them fried chicken, coleslaw, and a beverage. And that's one of their incentives. On level C, which stands for community, it's the first time that they're actually going out into the community. So they'll receive up to 2 community passes. Since right now our milieu is composed of girls, a lot of the time what they want to go do is do their nails or they want to go get their hair done. So we'll go ahead and we'll take them on a staff pass to do their nails or their hair, go watch a movie, whatever the case might be. Level D stands for discharge. So once they've reached level D, by now they've not only had community passes, they've also had home passes. So we allow up to 2 home passes. The first is a bit shorter, so anywhere from 6 to 12 hours. They can, whatever the family feels comfortable with. The youth returns back to the unit and we process what that home pass looked like. And then the following home pass would be an overnight stay. So being able to sleep in their own bed and have a couple meals with their family and see what that looks like prior to being discharged. So we reinforce progress using a variety of incentives, like I've just talked about: praise, certificates, passes, outings that promote internal motivation and responsibility. So when consequences are necessary, we use personal processing time. So we do also have a structured consequence schedule. So it depends on what they do that's considered a maladaptive behavior, whether that's considered a minor consequence or a minor maladaptive behavior or a major consequence for those major maladaptive behaviors. So depending on how many consequences you get a day or what kind of consequences you're receiving, we use personal processing time, which is essentially like a timeout, right? So it's a structured timeout style intervention for rule violations. During PPT, the youth complete educational and therapeutic packets to promote insight and reflection. So they'll be sitting separately from the rest of the youth who will continue engaging in the activities of the day. And it's the fun activities, right? They're still doing their schooling with the rest of the peers. They're still group therapy with the rest of the peers. They're still doing their individual therapy as well. But those like fun, creative art therapies, that's kind of where they'll sit separately and they'll complete therapy homework. Sounds fun, right? So after completion, they are placed on the good graces and they can return back to their scheduled program with their peers. This approach ensures consistency, accountability, and therapeutic momentum with the unit. And I promise you, they hate PPT. Like PPT in this unit is a bad word. So that's just a little bit about our behavioral modification program. Next, I'm going to talk about the treatment modalities and the evidence-based practices that we use here. So we employ techniques such as cognitive behavioral therapy, dialectical behavioral therapy, and trauma-focused interventions, heavy on the trauma-focused. These therapies are pivotal in addressing specific mental health conditions, resolving personal issues, and aiding residents in managing their emotions and behaviors effectively. So group therapy, we offer sessions that include anger management, substance use and relapse prevention, as well as DBT skills and process groups. We have group therapy every day, 7 days a week. So we do have the clinical team here present every day of the week. These sessions are not just therapeutic, they're vital for building a supportive community where residents can learn from and lean on each other. And they really look forward to group therapy. It's quite interesting. So in family therapy, our focus is on strengthening family communication. So we involve the families that are deep in treatment, and we also get them involved in the discharge component. So what would that look like? And teaching effective parenting skills. We believe that the family involvement is crucial for the long-term success of our residents once they leave our care. The family therapy component does start on level A, so it's kind of like that first incentive for the youth to level up from the first level I to level A. We have seen youth where, I mean, they're avoiding level A due to the family therapy component at all costs. So at that point, of course, we use our clinical judgment and we say, you know, this youth is taking a little long on level I. Why might that be? Let's go ahead and get started with family therapy. But for the most part, it does start on level A. So we also have our medication. Oh, and I actually just saw a question pop up. Yes, drug tests are done actually before and after the community and home visits, especially for those, for everyone in the program, but especially for those in our JARF program. So medication management, it's also a key component of our treatment approach. We closely monitor and adjust medications as needed while educating both residents and their families about potential side effects, ensuring that medication supports rather than complicates the recovery process. Lastly, we have our recreational therapies. So we have at this time 2 different kinds of third-party agencies come and offer recreational therapies. Of course, they have to pass all their DCF fingerprinting and they go through all of that before they can enter our unit. And they offer expressive therapy such as art, music. They'll also play sports. These activities are not only enjoyable, but they're crucial for building coping skills, enhancing self-esteem, and providing residents with healthy outlets for expression. Each of our modalities plays a unique and vital role in the rehabilitation and growth of our residents, and together they create a robust support system that's essential for recovery and personal development. All right, so discharge planning and aftercare. So I like to say that discharge planning starts the moment that the patient is admitted. So if they're admitted and the court order says 90 days and we're taking up to 3 months, figuring out what that's going to look like. So as we transition our residents to lower level or higher level of care, depends on the needs, our focus is to ensure a smooth and supportive shift. This involves outpatient therapy, continuous medication management, and reintegration into educational environments. Crucially, we coordinate and attend detailed suitability assessments for youth under DCF to determine the most appropriate lower level or placement level of care. We also prepare through thorough SIP referral packets. So we'll go ahead and if a patient meets criteria to be leveled up to a SIP placement, then we'll go ahead and we'll prepare the referral packets for the community youth. Typically, DCF helps us with the referral packets for the DCF youth, ensuring that their families are integrally involved in the process. We recognize the importance of leveraging community resources such as support groups and specialized programs that can offer ongoing support. Collaborating with key agencies like child welfare, the juvenile justice system, and educational institutions is vital to create a supportive network for our residents. So that's what our discharge planning looks like. As I said before, we collaborate with other agencies, such as the child welfare, juvenile justice system. We also do, so part of our discharge planning, this doesn't occur for every youth. Obviously, it's dependent on what their needs are. We also provide psychoeducational and psychological evaluations. So if a youth is suspected to either have an IQ that's either borderline intellectual disability or lower than 70 or whatever the case might be, we'll go ahead and we'll do cognitive testing to see what their needs might be once they do enter the community. Also, if we believe that a child is within the neurodivergent spectrum, we'll go ahead and we'll do an evaluation and then refer them for other resources such as APD, or the Agency for Persons with Disabilities. We'll go ahead and we'll prepare the packet for them. So follow-up protocols, the frequency of post-discharge checks, phone calls, or appointments. So we do a 7-day medication follow-up as soon as you're discharged from our unit. They have to attend a 7-day medication follow-up, and it has to be in person at Citrus, in the Citrus outpatient psychiatric program. The appointment is, so as I said, with the outpatient psychiatry team, and it will include a 30-day medication supply with instructions from our nursing team. So even when they're leaving us, they're receiving a medication supply, and as soon as they go to their 7-day medication follow-up, then that's also where the outpatient psychiatrist deems what is necessary and any changes, or if they're keeping things the same, what does the next supply of medication look like, etc. So Ms. Lewis just stated that there was a question in the chat that food may not be a good reward for the youth. I mean, I understand what the concern might be, especially if those youth have any kind of body image concerns or any kind of disordered eating behaviors. That's why they're very interspersed, and it's only 2. The rest of the time they are not, I don't want to say a diet. They're not really on a diet while they're here, but we do closely monitor what it is that they're eating. We do have. I'm sorry, Ms. Lewis, are you going to go ahead and?
Yeah, I'm going to interject for a minute. So from an administrative standpoint, the meal plan here is approved by a dietitian that was approved by DCF. So everything they eat here is based on that diabetic and or meal structured plan if they're identified as diabetic. Also, if they do have a meal pass and they're only allowed 2, those meal passes are also from selected places that have been approved by the nurse on site. So there's certain meals that they can only choose from. And there's only certain things they can eat at certain places to ensure that we're still meeting the requirements of, what is considered nutritious, meets the requirements if they, let's say, are diagnosed with high cholesterol or they have diabetes. So we're always trying to make sure the dietitian, the nurse, and the doctors are on board with the meals that they're being provided.
I did also want to say that we're trying to, view food from a balanced perspective. Food is neither good nor bad. Food is food. So while we offer it as an incentive, there are some children that'll say, I prefer not to do the food pass, or I do prefer to do the food pass. We also allow the food pass to be a kind of reward that they could share with families. So a lot of the time we'll go ahead and we will provide them with the meal, and they can share that meal time with their families as well. So it's a different approach, but I do understand the concern. All right, so now we're going to go ahead and move on to the challenges and the special considerations. So first, when it comes to behavioral management, we use a trauma-informed lens. Many of our youth come in with histories of complex trauma, So our team is trained in de-escalation techniques, structured reinforcement systems, and recognizing when behavior is a form of communication. Second, culture competence is a core value. So we work with families and youth from diverse racial, cultural, and linguistic backgrounds. Our team is bilingual and sensitive to the ways culture influences treatment engagement, family roles, and even symptom expression. So we actually recently had a child admitted from Yemen, and we were, we did everything possible so that they would be able to practice Ramadan, and and however they wanted to practice it, and the best way to do that. So we definitely tried to use cultural competence as a lens when treating our patients. Third, medication compliance is always a challenge, especially with teens. So we take time to educate them about their medications as well as their diagnosis, what the medications do, how the medications help. We also talk about side effects, and we're honest. So yeah, we're honest about the side effects. So we work closely with our psychiatrist and the pediatrician to ensure they feel part of the decision-making process. Fourth, often deal with legal complexities like the Baker Act or the Marchman Act, and these are constantly changing. So I definitely have my notes with me because the legal complexities sometimes trip me up, and there's different changes pretty much all the time. So there's legal hurdles, and so we definitely have our legal counsel that works closely with us. We coordinate with legal systems, public defenders, caseworkers to make sure we're aligned on safety and treatment goals. It's also not uncommon for the youth to be caught in multiple systems. So we have had youth not only be part of the DCF, but also the DJJ systems. And so collaboration is key, essentially. Finally, funding and insurance often present significant challenges. Our program is currently funded through Thriving Mind, a managing entity. If you are considering opening an SRT, it's essential to establish how the program will be financed, whether through collaboration with a managing entity or by proactively engaging insurance companies and other funding streams. So next, I'm going to go to another discussion question. So we just explored some of the real world challenges that come with establishing and sustaining a short-term residential facility, including staffing, legal, and funding hurdles. So I'd like to shift the focus towards solutions. So looking ahead, what one change, whether in policy or its funding, community outreach, would have the biggest impact on increasing the availability of SRT services for Florida's youth? Please share your answers in the chat, and I'll go ahead and take a brief pause. Ms. Lewis can go ahead and answer some of those questions for you. Thank you.
Okay, so for our program, because we're funded through Thriving Minds, insurance is not an issue. I know one of the questions that was asked is, can we support youth with special needs like handicaps or intense medical issues? So we are ADA compliant. And there is a medical clearance that needs to be obtained through our treating physician here. So some of the documentation that's going to be requested prior to them being accepted into RITS is medical documentation to support their current medical issue, if they have one. And then she'll make a determination as to whether or not we can sustain them at the program with the medical issue they have. I think one of the things that was mentioned in the chat is about funding in the police. I would think is one of the issues. So the police continuously are trained and should be trained on, you know, what constitute a Baker Act from their standpoint. I know there is mobile crisis that a lot of police officers have been utilizing, and they have set up within their municipalities various behavioral health people that can assist with assessments once they do come out to a scene and realize that they need additional supportive services outside of the legal requirements that the police provide. So I think that's a continuous training that needs to be provided to all law enforcement agencies across the counties. We're currently working on the statistics for the success rate because we are a new program. I would like to share with you guys something that one of our youth just recently wrote, and we've been getting this across the board since the program has started. And so it is a testament to what we're doing here and why we think the program is so important across the board. So she starts off by saying, the day I got here, I never wanted to open up. I never even believed that therapists would ever help me until later in the program. We grew some type of connection. And I mean, I feel like I was living in tears and regret and shame and heartbroken. And to be honest with you, I really felt like I lost myself. I had completely lost myself completely until I met you. Every thought of regret, every thought of shame, every thought of negative thought, you made them into beautiful thoughts for me. And I was able to find myself. I was able to be proud of myself. And then she goes on to say, I really don't want to leave here. I mean, you guys helped me so much, and I care for me and love me. And it hurts to leave you guys, but I know that I can do better. And I want to thank you guys from the bottom of my heart for helping me, because like I always say, I want to do better. So I think that that's one of the testimonies of one of our youth that recently left here. And she was a community child who voluntarily came here because she knew she had a problem, and her parents were on board with her receiving the services that she needed. So we consistently are getting these reports across our existence here. And so it's imperative that we continue to work towards helping all the youth who present with mental health issues, who present with substance abuse issues, to try to find their way back to who they are. Yes, there are the funding that is provided here. We seek the services that are provided here are not only for DCF youth, but it's also for community youth as well. So it's not without legal statuses, and I'm assuming you mean without being a citizen here. I need to look into that. So that's something we need to look into. But I believe Thriving Minds will be able to provide an answer to that question, because they are the managing entity for the program.
All right, thank you, Ms. Lewis. So thank you everyone for putting your questions in the chat. I have seen some interest in some of the statistics. And so without further ado, I'm going to get into the program utilization metrics. So again, we are a first of its kind lockdown short-term residential facility that's not even 2 years old. So we're still working on the program utilization metrics, but I do have some to share with you. So let me go ahead and share those. So this slide shows the trend in admissions for the RITS unit from Q1 of the fiscal year 2023 through 2024, all the way through Q2 of fiscal year 2024 through 2025. So we officially opened the unit on September 18, 2023, which is reflected in the low admissions during Q1. That quarter only includes a small portion of operational time, which explains the single admission. As we moved into Q2 and Q3, we saw steady admissions, 5 in each of those quarters, as referrals began to increase and word of the program spread. There was a slight dip in Q4 with 4 admissions, but we believe this was more of a reflection of case complexity and timing rather than decreased demand. So again, keeping in mind some of those things that you put in the chat, sometimes obtaining court orders takes a long time. Sometimes children get discharged from the CCSUs prior to any kind of, court order being obtained or any kind of referral packet being put together. So keeping all of these things in mind, right? So that's kind of why we talked about it earlier on in the presentation. So then we move into fiscal year 2024 through 2025. and we see a clear increase to 7 admissions in both Q1 and Q2. So this rise aligns with the unit becoming fully established, stronger collaboration with referral sources, and consistent program visibility. So overall, this upward trend demonstrates not only growth in volume, but also reflects the trust that the community and partners are placing in our program, and we definitely hope that this continues. So some more program utilization metrics. This slide shows our average daily census from Q1 of 2023 through 2024 through Q2 of 2024 through 2025. So Q1 reflects only a partial quarter because we opened in September 23, which explains the low starting number of 0.14. At that point, we were just beginning operations, hiring staff, and slowly admitting our first patients. By Q2, we saw a significant increase to an average of 2.34 youth per day, and then in Q3, that nearly tripled to almost 6, showing how quickly the program gained traction once fully operational. In Q4, the average dipped slightly to approximately 5, which we believe was due to the timing of discharges and a few delays in the referral pipeline, as I stated in the last slide. And then as we moved into the current fiscal year, we began to see steady growth again. Approximately 5.5 in Q1, and now over 7 in Q2, which is the highest we've had to date. This growth shows increasing demand and strong community partnerships, but also speaks to the efficiency of our admissions process and our team's ability to maintain census while upholding clinical integrity and safety. And this is our final slide of program utilization. So this slide shows the average length of stay for youth admitted to the RITS program. In Q1, our average was only 6 days, which makes sense given that we opened mid-quarter on September 18th, 2023, and only had 1 admission during that time. From there, we saw a gradual increase anywhere from 36 days in Q2 to 67 days in Q3, and then peaking at 96 days in Q4. This program reflects our growing caseload of youth with complex needs and longer treatment courses. In Q1 of fiscal year 2024 to 2025, the average dipped slightly to 77 days, which we attribute to a couple of discharges that were expedited due to external circumstances or rapid progress. By Q2, we saw the length of stay increase again to 99 days, which actually explains why now the Florida legislature has allowed us to ask for up to 180 days. So that increase to 99 days aligns with our clinical goals. So it's around 90, but still demonstrating that some discharges do take a little while longer. And it provides adequate time for the assessment, the stabilization, the trauma processing, and the discharge planning. This overall trend is encouraging. It shows that we are increasingly receiving appropriate referrals for our level of care, and that we are able to retain youth long enough to make meaningful therapeutic progress.
So I wanted to add that the data does not reflect the JARF youth that we have serviced since we became a JARF receiving facility. So this data is only SRT focused, and it does not reflect the JARF youth that we also provide services to at the same time. One of the questions that Ms. Rojas had was, are there any facilities with similar programs for males? So our program is for males and females. However, because we had an overwhelming amount of females referrals, is why the program became female-centered at this time. So there is no other SRT in the state at this time. Maybe there will be in the future. But at this time, we're the only one. And based on the clinical milieu we have now, we're female forward. But we were programmed for both, and then we end up getting an overwhelming amount of female referrals, which kind of geared it towards the female population right now. And as an influx of a program, and we continue to evolve, and we're continuing to work with what we're being provided in the community, that may change in the future. But we're currently right now in a position where we have female youth who are receiving the services that they require and that they need based on what's in the community, based on the psychiatric evaluations, based on those who went to court to seek us additional assistance for their youth, and those parents and youth who said, listen, I need help. And the parents are saying, we need you to help our youth, and we're both on board for the services that you're going to provide. And we know it's going to be tough, but we're willing to do the 90 days or the 180 days or the 60 days or whatever is required to get them the help that they need.
Thank you, Ms. Lewis. So I'm going to go ahead and continue with our slides. So here we talk about measuring impact and ensuring quality. So this slide speaks to how we evaluate and improve the quality of care provided by the RITS team and in the RITS program using both data and structured quality assurance practices. Starting with key metrics, we've seen a steady increase in our average daily census and the average length of stay, which shows that we're receiving appropriate referrals and maintaining youth in care for meaningful treatment durations. We're also beginning to track a reduction in psychiatric hospital readmissions and improvements in therapy engagement and family involvement, which are strong indicators of clinical effectiveness. Next, I'm going to talk about quality assurance. So when it comes to quality assurance, we invest heavily in training and clinical supervision. Staff participate in ongoing learning opportunities and case consultations to ensure they're using best practices. We also conduct program reviews to make sure that we're delivering trauma-informed and culturally responsive care. Importantly, we also undergo peer reviews both internally across departments as well as externally from insurance agencies. These are critical because they bring a fresh, objective perspective on the work we're doing and help hold us accountable to both clinical standards and payer expectations. It's an important part of maintaining trust with our stakeholders. All right, we also have feedback loops. So client satisfaction surveys are completed by youth and the caregivers at discharge. So actually, earlier on, Ms. Lewis shared one of the client testimonials, which the client herself wanted actually to be part of the presentation. We were like, no, that's a HIPAA violation, it's all good. But she was able to just write us a letter and said, at any point in time, I want you to share this because my stay here was really meaningful and it changed my life. So we're always listening to the feedback of clients and informal word of mouth reviews from caregivers, youth, and referral sources. We use that input to inform program changes, improve communication, and refine our approach. Staff also participate in team debriefings to reflect on what's working and what can be improved. This actually happens, I want to say sometimes the debriefings can happen on a daily basis, sometimes on a weekly basis. So it depends on what's going on in the unit and just how often the debriefings are necessary. So I did want to add some resources and references. So these are just some of the resources that we've been able to use and have helped us. So community and family support. So Citrus Health Network, of course, provides a full continuum of care, outpatient, school-based, and residential services like RITS. It also has its own SIP placement. So CATS is the SIP placement for Citrus Health Network. We also we're partnered with Brave Health. It's a great option for youth that are transitioning out of residential care who still need virtual psychiatry, therapy, and group support. We also partner with Here's Help, which focuses on substance use treatment and vocational support, which is often needed by the teens that we serve. Further community and family support, we've listed NAMI, so NAMI, the FBHA, as well as a 211 helpline, all important access points for families that are navigating the system. So with respect to clinical and diagnostic tools, of course, we refer to the most recent Diagnostic and Statistical Manual of Mental Disorders put out by APA, DSM-5-TR. We use American Academy of Child and Adolescent Psychiatry resources, as well as National Child Traumatic Stress Network resources. With respect to professional development and policy, we list organizations like SAMHSA, the Child Welfare Information Gateway, and NASW, which are excellent for ongoing training, staying current with policy changes, and accessing evidence-based tools. So with respect to the legal framework, which is ever changing, specifically chapters 394 and 397 of the Florida statutes, which cover the Baker and Marchman Acts, we've listed them here. These are critical to understand when working with involuntary placements and youth that are involved in the behavioral health or juvenile justice systems. We've also listed the DCF website, which is also a useful hub for state guidelines and system level updates. I've also included here our JARF citrus brochure. So it goes over key information, like what to expect at admission, the discharge process, available internal and external resources, confidentiality policies, and safety guidelines. It's a helpful overview for families and providers alike. If you'd like a copy, please let us know. Our host today can email it to you after the presentation. And last but not least, I would like to end our presentation with a discussion question. So I want to invite you to reflect on what stood out most and where you'd like to continue growing and where we should continue growing, right? So we've covered a lot of groundwork from the referral processes and the program structure to challenges, outcomes, and resources. Each of these areas could easily use its own deep dive. So which area would you like to explore in greater depth after today's session? We have best practices in clinical interventions for adolescents and SRT, strategies for collaborating with community partners and families, navigating legal and funding mechanisms for establishing new SRT units, building a sustainable and qualified workforce for adolescent mental health programs, and implementing and measuring outcomes for quality improvement in SRT services. Go ahead and put your answers in the chat. Feel free to just put the letter. We're going to go ahead and have these messages sent out to us afterwards, just so we could take a look and poll to see what the community wants to know more about. So I do want to leave the discussion question up so you guys can go ahead and see the options for about a minute or two longer. And then we'll go to our last slide where it will give just contact information in the event you want to contact RITS, Thriving Minds, or Citrus as a whole.
Okay, so I see that there's varying answers to the discussion question. Some of them are talking about building a sustainable and qualified workforce for adolescent mental health programs. So I'm going to touch on this one at this time because as an administrator, this is always a very difficult population of youth that you're trying to serve. So when you're trying to find staff that are committed to helping this youth, it can be very, very, very challenging. And it's outside of the financial component of it, it requires a level of understanding, a level of empathy, a level of compassion, a level of support that these youth need that a lay person may not necessarily be in a position to do. I joke all the time and I say, this is not a job for someone who just wants to make sandwiches. This has to be a job for someone who has a vested interest in wanting to see something better for the population that we serve, because they do present with, at the time, a very difficult situation, whether it's related to substance abuse, whether it's related to mental health. And so they need a staff person, a supportive person who's going to be able to not only empathize with them, but be able to also cultivate them and create in them a character that when they have these type of issues, they're able to use those coping skills or those behavior modification skills to kind of put themselves in a better situation. So as an administrator, I'm always trying to find a population of staff, support workers, case managers, clinicians, clinical teams that are willing to provide what is needed to help them. Also, they talked about best practices in clinical interventions for adolescents and SRT. I don't know if you want to touch on that for a minute, Dr. Felpeto.
Yeah, definitely. So, I mean, this would be a great presentation on the different kinds of clinical interventions that we use, especially for those in SRT. I mean, at the end of the day, SRT and JARF, right? So our program as a whole, it's the population that we're serving are adolescents that need to be stepped up from a crisis stabilization unit. So at that time, they might not be ready to be out in the community and use this time to be in here to kind of learn coping skills, to learn emotional regulation skills, process their trauma, etc. So I think a presentation on just what those best practices for this population specifically would be great, and you know how that evolves, and other kind of clinical practices that we can include as well, right? So in our unit right now, one of our exclusionary criteria is a neurodivergent population, just because we don't have all the resources that they might need. So an SRT with occupational therapy, with ABA therapy, RBTs, et cetera, what could that look like in the future? And of course, you know, what would the legal and funding mechanisms look like for that? So thank you for the interest in that. All right, so please do feel free to continue adding your questions and your comments in the chat. This is the last slide, and it's just you know, our contact information. So we have our RITS email on there, as well as Thriving Mind, our managing entity. Thank you so much. I believe some of you were here today, so I definitely want to go ahead and say thank you for being present and for funding our youth and our program. That is the information for them as well. And I'm actually going to go ahead and pass this back to Robert so that he can close this out. Thank you, everyone, for being present today.
Thank you so much, Dr. Felpeto and Ms. Lewis, for your time. I do want to give everybody just a minute to see if you have any questions that were either not answered or have come up, just to make sure we do have some time left over. But want to check and give everybody a minute, see if you have any questions before we switch to the conclusion PowerPoint. Okay, not seeing any, so we do have the emails up here. I'm going to switch to the conclusion PowerPoint. We ask everybody to hang on for just a moment while we conclude the webinar with some business items. The first thing I would like to say is that we are going to post a link to the files in the chat. There is a PowerPoint, there is the admission pamphlet that was mentioned, and then there is the evaluation. So all three of those are posted there now. I will post them again in just a moment. Before I continue, I did just see Dr. Felpeto, Ms. Lewis, I'm not sure who wants to answer. What are the denial rates from insurance providers once in treatment? I believe the answer to that is that insurance is not a factor because it is covered by DCF through a managing entity. So insurance is not a factor. There should not be denial rates because DCF covers this treatment. Continuing on with the conclusion, the links are there in the chat. I will post them again in just a moment, but I want to take a minute to thank Dr. Felpeto and Ms. Lewis for both of you for your time today. It was a great presentation. I know it's really valuable information talking about short-term residential treatment, and I hope that it was beneficial to all of our participants, especially in raising awareness and potentially getting more short-term residential treatment programs throughout the state. So thank you guys both so much for your time. I have posted a link to today's evaluation in the chat. Additionally, when I end the webinar in just a moment, your web browser should populate a message that looks like this on the screen. It will say the host or presenter would like WebEx meetings to open a website on your computer. That is WebEx trying to automatically redirect you to the evaluation. So don't close out of that. If you click continue, it will automatically redirect you at that point. You must sign into your FATA account to complete the evaluation. If this is your first webinar and you do not have an account for on our site yet, you can register for one at no cost. Under the sign in menu is a button that says haven't registered yet. You can go ahead and click that and create an account. Please use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. That is the only way for us to connect your attendance during today's webinar with your evaluation completion. For CEUs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or edit your license number, you may do so by logging in and clicking edit on the professional information section of your profile. You will get a third opportunity to complete the evaluation through a follow-up email later today. As a reminder, the evaluation will close this Friday, May 23rd, 2025. If you need assistance logging into your account, registering for an account, or completing the evaluation, you can fill out a contact us form on our website or email us at training@floridabha.org. As a reminder, we do not email statements of credit. Instead, once we've verified your attendance and the completion of the evaluation, a statement of credit will be posted to the professional development section of your profile in your FATA account within 30 business days. You must have attended the entire webinar and completed the evaluation for a statement of credit. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's presentation will be available on our website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again, Dr. Felpeto and Ms. Lewis, for your time. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.